Hi, I'm Kenneth Adams, a cardiologist at Pentucket Medical. I'm hosting this episode of Matters of the Heart. I'm happy to have with me today Dr. Seth Bilazarian. Dr. Bilazarian is going to be speaking about a very interesting topic that I think people will really relate to. It's human aging and cardiovascular disease.
Great. Well, thanks, Ken, for joining me today. I just started thinking about this recently because recently we have been referring patients for a relatively new procedure. It's replacement of a heart valve using a catheter rather than an open surgical procedure, and I know you've sent several patients for this as well. But the thing about it is these patients are often very old. I've sent, in the last 2 months, I've sent 7 patients ranging from 81 to 96, and 4 of them were in their 90s. And it got me to thinking about like what's going on with age, and I haven't really thought about it very much, but you know, we all know that people are living a little bit longer, so I wanted to talk a little bit about it and get some sense about it. So I want to talk a little bit. So right now, the current life expectancy for Americans is about 78 years old. So sometimes I like to joke that a patient will say, well, what's normal for me? I'm 80, what's normal for me? And actually what's normal for an 80-year-old is to be dead for 2 years because 78 is average. So if you're already 80, you're already above average for America. So that's the great news. And we're seeing a lot of patients who are going well past 78. But one other fascinating thing that I found was that, of course, we know it's increased. So in 1900, if you were born in 1900, your average life expectancy was about 47 years. So if you're born in 1900, you lived to, on average, about 1947. If you skip up to 2009, the most recent year we have data, if you were born in 2009, you're expected to live about 79 years. So this is really a dramatic improvement. But one thing I wasn't aware of is that the data is actually collected based on how many more years you have after certain ages. Mm-hmm. And if you live to age 65 in 1900, you on average live 12 years. But if you lived to 65 in 2000, a century later, you lived 18 years. Now that's a good increase, that's 6 years, so I don't want to belittle that, obviously, as I'm getting older, right. 6 years would be nice to have 6 more years. But it's what a dramatic difference. We're talking about 47 to 77, 30 years in total life, but only 6 years if you make it to 65, implying that a lot of deaths happening in the early part of our last century were really in younger people, dying at young age, either infant mortality, dying in childhood from infections, dying in their 20s and 30s from a variety of things, occupational hazards or other kinds of things. Going forward, so living to 65 was really a good thing, and currently, if you live to 65, you've got almost 20 more years on average to go.
That's impressive.
So some other things that I just learned that I just probably knew but didn't really think I really had hard data on. If you look at all ages, the sexes are about equal, so about half men and half women in the United States. But if you make it to 65, it goes 60-40. Women are 60%, men are 40%. But if you get to 85, it's 70-30. We know women live longer than men on average, but there's a lot more older women than there are older men. And just to use my example of the patients I sent for this procedure, all of them except for 1 are women. So I sent 6 women and 1 man in their 80s and 90s because they live longer and are susceptible to these diseases related to older age.
Very interesting.
So, so that's some of the other things. So one of the other kind of fun things that I read is that the percentage of Americans that are age 65 that are expected to survive to 90 has increased. So in 2000, it's 28%, but it's not as many as half of people when we get to 2050, the mid-century, 40 years from now. You and I won't be around, but some of in our audience may be. That 42% of people might live to age 90 if they just get to 65. So that's increasing from the 17 years to almost 35 years. It's pretty impressive. So, and then the number living to 100, in 2000, there was 72,000 Americans who were 100 years old. There's 130,000 in 2010, and by 2020, that's only 7 years from now, it's going to be double to 214,000. It's just going to keep going up. So it's so special. You know, there's this Good Morning America segment that yes. He celebrates. He's not going to be able to do it. In 2030, there's going to be 300,000 100-year-olds. I mean, you couldn't do it. So it's just, it won't be. He'll have to do 110-year-olds or 120-year-olds.
I think the president will be busy too because I think the president sends a letter to everyone who becomes
Oh, he does. He does. I bet it's a form letter though. So those are some interesting things about longevity that I thought were interesting. The other thing that I also thought was very interesting is we know, unfortunately, in America that there are differences in race with regard to longevity, that white Americans live longer than non-white Americans, whether Hispanics or blacks, that the total life expectancy is longer for white Americans than it is for non-white Americans. But if you live to 65, regardless of if you're white or non-white, the differences are gone away. Again, speaking to a lot of whatever is wrong or bad in the society for minority groups or healthcare delivery, whatever, we don't know what the reasons are, but there are theories, but it seems to go away. So if you're a non-white American, you live to 65, you have equal chance of living to 80 as a white American. I thought that was a fascinating thing.
That's very interesting. I never thought of age 65 as being a watershed mark where if you hit that, you're good to go for quite a while longer.
Right. Well, the cynical thing that I would say is that I think most people know is that when during the 1940s, when Social Security first started, the average life expectancy for a 65-year-old was only about 2 or 3 years. So the age of retirement was 65 years with the anticipation we would pay for a society for health and other benefits for only a couple of years. Right. So that's one of the challenges that we face. So that's sort of the issue. 42% of all Americans in 2000 as I mentioned, are expected to make it to 85 who are 65 years old. So it's going to be a lot of these folks who are called baby boomers, people born between 1945 and 1964. So the next thing I want to just talk a little bit about is this whole concept about aging. So the concept about aging, we learned about this in medical school. Everybody knows about it. There's fetus, there's infant, there's early childhood, there's adolescence, there's young adulthood, middle age, old age. But these are really very artificial, and you and I see this every day in our office. We'll see a patient at 10 o'clock who looks incredibly vital, is upset because we're a few minutes late because they got to get to play golf, and they're 80 years old. And the next patient afterward looks like they're really not doing very well. They look very old, and maybe 60 years old. So the chronologic age, the calendar age, is not always consistent with what looks like with biology. Just with our own eye, we can see how vital someone is. Doctors are really trying to get a handle around it. We're actually creating, not we, but the medical societies are creating indexes, something called frailty, just to try to measure. And very simple things are being used. How fast someone can stand up from a chair, how fast they can walk a few feet, are being used as strategies to say, how can we sort of assess someone in a very crude way about their ability to withstand medical treatment and go forward.
Interesting.
So human aging, what is normal in the aging process? And I think that everyone knows that there is a greater susceptibility to disease as we get older, all kinds of diseases. But there is a lot of heterogeneity. There's a lot of differences. There's some people who are very vital and are resistant to disease, and some people are much more susceptible to disease. It does sadden me sometimes patients who have difficulty say, I looked forward to this part of my life, the golden years, they're not very golden. And it's very complex, and I think that we all know, and I think these patients who tell me know without being told, that some of it is genetics. Some of it is what's happened in their own environment, what they may have done to themselves by not taking care of themselves or smoking or other kinds of issues. But some of the things we just don't know that are causing their current circumstance.
I wonder if there's a fair amount, I don't know how you can divide up the percentages of what contributes to it in terms of how much genetics contributes to it. There's this concept of cell death called apoptosis, where it seems like the cells in our body are sort of almost pre-programmed as to how long they're going to be viable. Do you have any information about genetics versus non-genetic causes?
I think that people are trying to reach for that, and I think that clearly what you're saying is right. And I would say just like we know that there's genetic predispositions to certain diseases like heart disease, I think that they are probably amplified by doing bad environmental things. So if you're really have a good genetics, you probably could get away with not doing good things to your body, but since you don't know, I think we try to encourage all patients to take care of themselves with the hopes that will have a positive impact. But no, I don't know, but certainly the crude way you and I have talked about is just asking patients how long their family members lived. I ask patients, often if a patient will tell me that their father or their mother died in their 60s, I'll often follow up with some basic questions like, did they smoke? Did they take care of themselves? What was their cause of death? Sometimes people died from accidental death, so that helps clarify whether that's going to have an impact on their longevity. So I think that there's a variety of things. So successful aging is a term that I think that we're striving for. I think you and I are striving for ourselves, but we're striving for our patients. And I think that there's a variety of things that there is this sort of range of responses to aging that people will have. I think that there's a positive pathway that patients can take by making, impact of exercise and keeping strength up. It's really becoming very clear that just the ability to walk can be a really strong indicator of lifelong longevity and quality of life. I sort of been using it in my own office. When I see my patients, I take them from one room to another room, and they don't know this. This is a secret, so everybody in the audience, I'll ask them to keep it a secret, but I'll actually sort of watch them walk and see how fast they can follow me back to the room. And it's a pretty good indicator. If they take a long time to sort of get out of the chair and follow me, they're more likely to be frail and have a greater difficulty going forward.
Yeah, there was a recent article about people with dementia and how you can ward off dementia by remaining active. So I thought that was interesting.
Yes, and there's also, speaking on that, not to get off the topic, but even diet. I mean, the Mediterranean diet that's being touted is also another article on that with regard to dementia. We know that sort of vascular health, we're cardiologists, we're highly vested in keeping our blood vessels healthy, but the blood vessels have so many important impacts, and the brain being a chief among them. So why is longevity increasing? I think that's what we would certainly be interested in. I don't think anybody has an answer, but there's a lot of theories about why we've went from, in the 1900s, living to the 60s as sort of the best outcome, to now living into the late 70s and likely going beyond. I recently saw an advertisement, an insurance company had a billboard that said, the person that will live to 150 is alive now. So some child, presumably, that's alive now and in their teens will live to 150. So that's pretty remarkable that's happening. So why is that? Well, I think that there's a lot of potential impacts, but I think some of the crude reasons is that we've wiped out a lot of things that killed children, like infections, with the rise of antibiotics. I said children, but children and young adults. I think a lot of public health reforms. We have better sanitation. People don't die from cholera or other infections from bad water. We figured out that we don't put our sewage with our drinking water. The crude of those people who enjoy American history might visit Sturbridge Village, and you can learn, if you take a tour there, that they would put the outhouse right on the river, and then, 30 feet down, people were getting water out of the river from where the outhouses were just upstream. Right. So those kinds of things that we think are silly are obviously a huge impact on health. We like, as physicians, to think that there is a contribution to medical technology. There are advances in medical technology that are improving. And even simple things about rising living standards. People don't live in garbage-infested places. We now have indoor plumbing, which takes away human waste that doesn't pile up in the homes, and that contributes, obviously, to health as an outcome. So a lot of those sort of low-lying fruits, so to speak, that have really made a huge impact. But I think from cardiology perspective, some other things. I think that some older patients in our audience may have heard of rheumatic fever. There was a variety of terms it was called, St. Vitus dance or cholera or other kinds of things, contributed to significant heart disease. Those things have really been eradicated with penicillin and other antibiotics. But we think that perhaps people who didn't even know they had rheumatic fever may have had a sort of low level of infection that could have contributed to their outcome over long term. So I think that that's a really big thing that we think is making an impact as we go forward. And I think that we live here in the Merrimack Valley, and we're very proud of our history as mill towns in Haverhill and Lawrence and Lowell. But of course, these towns had mills that did not have very good industrial standards for their workers, and many workers may have died acutely from severe injuries that occurred during their mill time, but may have had longer-term chronic illnesses from inhalation of fumes and dust and other kinds of things, and died for a variety of reasons that we now appreciate can be protected with better working conditions. So a lot of things, I think, contribute to longevity, and it was a great review for me to think about these things and about how far we've come in terms of this.
So we've given people that chance to get to that threshold of 65.
Exactly.
We've eradicated a lot of things that would stop them.
Right, exactly. I think that's exactly right as you said it. So just to skip ahead now, I just want to take the last half of our show just to talk a little bit about aging and cardiovascular disease. So I'd love to have your input about this as we think about this. So thinking about age and cardiovascular disease, there's a famous quote from an English physician named Thomas Sydenham, who said, "A man is as old as his arteries." And I think, as we went on a little tangent there briefly ago about dementia and other issues, If your blood vessels are not healthy, if they have plaquing in it, this problem called atherosclerosis, then all parts of our body, our liver, our spleen, our kidneys, our brain, every part of us doesn't get the blood supply, and little pieces of this plaque can chip off and just cause little tiny problems that we don't even identify. I saw a patient today, a 65-year-old man who had a stroke. He thought it was his first stroke, but when he had his MRI for his brain, he actually had a prior stroke that he didn't even know about. So these kinds of things are from patients can happen because our vasculature or our blood vessels are not healthy. And that's really where we're trying to move all citizens to better health for diet, exercise, and treatment of blood pressure and cholesterol. So I think that's the first thing that I would say. So the other thing that I would say is that age, although on one hand, I'm sort of going to say the opposite, but on one hand I said that people have a variety of responses at age, so an 80-year-old can look like a 60-year-old and vice versa. We really do put a lot of stake in aging. When any two physicians talk, when you and I talk, if you have done a catheterization as you will do on a patient and you're telling me about the patient and asking me if I should do the angioplasty, the first thing you tell me is the patient's age.
Right.
You'll say, this is a 65-year-old man, this is an 82-year-old woman. So we do take a lot of stake in it because we recognize that that is an important risk factor for whatever we do for patients. So I thought that was interesting. Any comments on that?
Yeah, I was just thinking about that. My mother is elderly and healthy and just had a series of some medical setbacks. And I could see through the eye of a son that how frail people in that age group can be. So even though they've gotten beyond 65, they've gotten beyond 80, it can be tenuous. So we're always so careful about how aggressive we should be in terms of treating somebody in an older age group.
And I'm going to come back to that, and I'd love to talk more about it, and maybe hopefully we'll have time. But what you just said is the really hard thing, because on the one time we want to be careful, but we don't want to be so careful that we don't do things for patients that could help.
Right, just because they're older.
Just because they're older. So the term for this, I mean, everyone knows the term racist. A racist is a person who treats people based on their race. And there's a term called an ageist. You just treat patients or treat people based on their age. So you're old, you can't do that. You're old, we shouldn't do this. And we really don't want to do that. But on the other hand, we want to seriously consider that age does have an impact. So it's a very complicated thing. So we know that there's a variety of things that are important with regard to aging and cardiovascular disease. We have talked on this show about this irregular heart rhythm called atrial fibrillation. The slope is dramatic, how much it increased with age. 60s, more in 70s, as many as 15% of 80-year-olds have this problem. A lot of 80-year-olds have this problem, so it definitely goes up with age. We know that the wiring of the heart, we call it the wiring, but the cells that conduct electricity through the heart, they get old. Patients who are older need pacemakers much more than younger patients. It's very uncommon to do a pacemaker in a person that's 30 or 40. I've never done one in 30 or 40-year-olds. Often do it in 70 or 80-year-olds. We know that there's this other problem we mentioned earlier, the heart valve that opens up and lets blood out, called the aortic valve. That gets narrowed as people get older, called aortic stenosis. It's almost exclusively a problem of older people. And of course, you mentioned a show we did earlier about older people getting this problem called atherosclerosis. So all of these are older people problems. So we are dealing with them, and dealing with them with some kind of sensitivity is really important. So, I'm sorry, did you?
I was just thinking that I have the sense that as cardiologists, because we see so many elderly people, that we almost become immune to their age sometimes. Years ago, I remember if someone was in their 70s, I might think that was old and maybe I shouldn't be too aggressive. And now, after having been a cardiologist for many years, I often don't even think about the age. I kind of date, what's their visual age to me? What do they look like?
Uh-huh.
Are they 80, but they really are, they're active and they're vital and they're doing things, and make the decision based on that.
Right. So I think I agree with everything that you said. So you know, age is a variety of. So on one hand, I just mentioned that age has a big impact on diseases, but the other really hardship that I struggle with is age has a significant contribution to the risk factors for disease. So I think that one of the things I try to tell my patients is, some of my patients have done a really good job over the decades maintaining their weight. I've had patients who said, look, I weigh about the same as I did when I was in high school. It's not common, but a few of my patients will say it. But whether they're that weight or a little bit heavier, I tell patients you are fatter. They don't like to hear this, but the data has been really extensively evaluated. And because we all lose muscle mass, If we're the exact same weight, 60, 70, 80, we're actually fatter when we're 80. And it's a hard thing to hear, but that's really an important concept. And studies have actually been done where people have done MRIs of a thigh at every decade of life, and you can see the same thigh has less and less muscle and more fat. So that's one of the problems with aging. A second problem is that the cholesterol rises into our 50s and 60s. It doesn't rise much after 60s, but with age, our cholesterol rises. So that's another risk factor for heart disease. Another risk factor is that blood pressure rises with age. A fascinating study I saw was that in the Framingham Heart Study, right here in Framingham, Massachusetts, they looked at people who were at age 50, did not have high blood pressure. And if you looked at just those people who did not have high blood pressure at 50, 85% of them went on to develop high blood pressure, needing a medicine before the end of their life. So blood pressure rises with age. And of course, blood sugar rises with age. Many people develop diabetes. So all of these risk factors. So should we treat them? Or if someone's doing fine and they're 80, should we leave them alone? That's a really difficult situation, and I'm being clear. Any thoughts on that?
I think we tend to treat them.
Okay.
You know, if they're vital and they're active and they're mentally, in a very good shape, I think we tend to just go ahead and treat them.
So you already said this, but the anecdote that I was going to share was similar to your experience. So this is my 20th year in practice. So 20 years ago, I was in my fellowship, and we would have a weekly vascular conference where the cardiologist and the cardiac surgeon would sit together, and we would look at catheterization films to decide, should the patient have bypass surgery or angioplasty? And I remember vividly the surgeon saying, this patient's about 70, probably shouldn't go to bypasses. The risk is too high. And now, I would have to not laugh on the telephone if I called the cardiac surgeon and I said, patient's 70 and he needs bypass, and he would say 70 is too old. I would say, are you
never
joking?
say that
Are
anymore.
you joking? It just would never ever happen. I don't think it would even happen with 80. I think it might happen with 90, but it wouldn't happen even with 80. So that's how in my 20 years of practice, we moved from 70 being prohibitive to laughable about not doing it. So I thought that was an anecdote that I recalled. The last anecdote that I just want to share with you, and I'd love your insight. So just this week, I saw a patient who's celebrating their 100th birthday this week. And 4 years ago, I met this patient at the hospital, at Lawrence General Hospital, came in with a very low heart rate. Their electrical system, the conduction system had just gone, and the patient's heart rhythm dropped to the 20 to 30 range. They had what's called complete heart block. And this is a very straightforward thing. You need a pacemaker. But the patient's 96 years old. The patient lives independently in an assisted living facility, but lives independently in their own apartment, has an enjoyable life, visits with family, and I recommended proceeding with pacemaker. The patient's granddaughter is a physician, and of course cares for the grandmother, wants the best, but strongly recommended we not do the pacemaker. The son, I recommend the pacemaker. So this is a situation that we're often in, and this has really weighed on me over the last 4 years, and it's wonderful to see the patient now 4 years later doing well and still living independently. So and I'm not saying this to sort of say I did the right thing, but just to stress how difficult it is. The really remarkable thing is that the patient had a very difficult course. A patient had repeated complications with the pacemaker. The pacemaker wire fell out twice and had to go back for surgery twice more. So oftentimes, we didn't mention this, but with older patients, it's often the procedures are more difficult. They're not very easy procedures because the older patients have more difficulty. So in retrospect, I think that this patient doing well for 4 years was validated. It doesn't make it easier the next time. Right. The next 96-year-old patient that I have, it will be difficult again. And we are seeing these patients now coming in for heart attacks. Should we do the most advanced treatment for heart attack, rush them for an emergency angioplasty? It's a very complicated situation. I don't have an answer. I'd love to have your insights about it. I guess I'll give you the last word, but I'll say, it's wonderful if you have a relationship with a doctor, whether an internist or a cardiologist, that you trust and you can, give the best advice. If you have a family that cares for you, that can be involved in the conversation and have a conversation about pluses and minuses of both doing it and the pluses and minuses of not doing it, and make a really reasoned decision. And of course, we want to make the best decision for not just the quantity of life, but also the quality of life. If you're in your 90s, if you live several more years and it's a lousy life, that's a different situation than if you could live several more years with a good quality of life. So that's my last word. I'm saying it's really hard, and I think it's going to be an increasingly common discussion that we have with patients. Give me your last word on that.
This has been very, very interesting. I've learned a lot from this, all the data that you presented. I think we almost automatically, when we evaluate a patient in the office or in the hospital, I think we take their appearance and their age into account almost automatically. And I think we also look at what we call their comorbidities. So
All the other diseases.
all the other diseases. Do they have kidney disease? Do they have lung disease? What's their outlook for the next couple of years? So as you said, there might be 90-year-olds who are very different from other 90-year-olds. I just had the experience today of a patient who I had sent recently for a bypass. He's 85. He's very viable. I really had no qualms or hesitation about sending him for a bypass. 15 years ago, maybe I would have thought differently because the techniques aren't quite as good. But yeah, this has been very, very, very interesting, this whole topic about life expectancy and how to treat the older patients, and should we be aggressive, should we pull back, make sure we have the family discussions, make sure the patient knows the risks. And we also understand how frail some of these patients can be. They might look great on the outside, but we worry about what's going to happen to them when we do procedures. So this has been very, very interesting. I really enjoyed it.
Great.
I'm Kenneth Adams. I've been here hosting this episode of Matters of the Heart, brought to you by Haverhill Community TV and Pentucket Medical Associates Cardiology. I've been very happy to have Dr. Seth Bilzerian here with me to discuss a topic that I think everyone can relate to. We're all trying to get as old as we possibly can, but not too quickly. Thank you very much. That was a great talk.
Thank you.
That's very interesting.